Hi, and welcome to the Restorative Wellness Clinicians Corner, a video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. Hi, everybody, and welcome to today's episode of the Restorative Wellness Clinicians Corner. I am really excited about today's conversation. We have Kim Vopni here, known as the Vagina Coach. Kim is a certified fitness professional and menopause support practitioner who has spent over 2 decades educating women and practitioners alike on the often overlooked world of pelvic health. She is the founder of the Buff Muff method and a go-to resource for clinicians seeking to better support pelvic health, especially through perimenopause and beyond. She's a sought-after speaker, a women's health educator, author of 3 books, and certifies other fitness and movement professionals to work effectively with women struggling with core and pelvic floor challenges through her Buff Muff method. That's a mouthful. Buff Muff method practitioner certification. Welcome, Kim.
Thank you. Lovely to be here with you. Thanks so much for having me.
Yeah, thank you so much for joining. I think this is a topic that I was sharing before we went live. This is a topic that's very near and dear to my heart. It's something that I've definitely struggled and continue to struggle with. And I know enough to get myself in trouble, but certainly not enough to be able to, definitely not to support others in it, but even support myself. So this is going to be a great conversation. So I just want to start off with your story. It sounds like it started from a very personal place.
Yeah.
So can you share a little bit about what got you interested so much in pelvic health?
Yeah, for sure. It's, everybody always asks me this question, and it's not like I grew up thinking, I want to be a vagina coach.
Right.
So really it started when I was very young. I remember being in 6th grade and seeing a childbirth video, and it was part of our sort of sexual and body health education. And that was really good, birth control. I said, okay, I'm not doing that. And so I grew up with this sort of fear fascination about pregnancy and birth. And I remember talking to my mom, and she was very open with my brother and I. She was an OR nurse. And so she was very body information positive kind of. But she shared her birth stories, and she had episiotomies, which is what was standard at the time, where they cut into the tissues within the pelvic floor. The intention was to make space for babe and make it easier, but it was creating more issues. And so again, that was another mark, checkbox. Nope, not interested in doing that. And so anyway, fast forward to I get married, and my sister-in-law is giving birth. She allowed us to witness her birth. And that was the first time I had seen anything that was kind of a normal physiological birth. Everything else was what you see in the movies, and people are holding their breath, and people say count to 10 and screaming and all this stuff. Right. And so that was a bit of a turning point for me. And I said, I was very empowered by that. She didn't have any tearing. She was using midwives. She was in a birth position I'd never seen before. And so the following year I'm pregnant. And now, of course, it's like, okay, it's go time here. How do I get this baby out without tearing and all the things that I've seen happen with my mom? And my midwives had recommended a biofeedback device to me called the Epino, which Epino stands for no episiotomy. It's from Germany. A doctor from Germany saw women in Africa using gourds of increasing size to prepare their pelvic floor and perineum for birth. So he thought, great idea, but not going to fly in North America or, more mainstream. So he turned it into a medical device. I used it. I had a great experience. And then I thought, why doesn't everybody know about this? And I contacted them and said, could I be a distributor in Canada? And my intention was not for this to be a business. I thought I'll just sell it on the side and help some of my friends and have a little extra pocket money. And that's how it started. And then a few years later, I was laid off from my job. I had been a personal trainer, then I transitioned into human resources, and then I was laid off from that job with the financial downturn of 2009. And I thought, okay, here we go. Let's turn this into a business. And as I start talking about this product, I had created a website. I was really talking about fitness principles to a specific group of muscles. And then I decided I should recertify my fitness. And I focused very much on pregnant women and new moms, and did that for a while. I had a site for pelvic health products, including the Epino. Then I was looking at, all right, I'm helping women prepare for birth. I created a program called Prepare to Push, but now we're really overlooking this postpartum recovery phase. So then formed a second business called Bellies Inc. with 2 other women. One was a pelvic health physical therapist. And we wanted to optimize postpartum recoveries and bring in traditional practices to more kind of North America culture. Then I start going through my own perimenopause journey, not knowing the term perimenopause at the time and wondering what the heck is happening.
Right.
And that opened up this whole other new chapter as it pertains to the pelvic floor. And so really this is so much more than what we've been told. Like a few people maybe are told, do your Kegels when you're pregnant. And that's kind of it. So really that's kind of the journey that brought me here. And now the population I work primarily with is perimenopause and postmenopause. That's a chapter of life where things are sometimes showing up for the first time, but usually little things that have been kind of naggy along the way that we've sort of been able to ignore are all of a sudden screaming at us with the hormonal changes that come with menopause.
Yeah, absolutely. I think you're one of the few people that I've ever interviewed where your experience moving into this was a positive one, in that you had the success that others didn't. Most people, you know, it's all this sort of drama and intensity that we've gone through. So that's really refreshing to hear that you found something that worked and immediately and had such great successes with it. So I want us to, you know, this is a clinician audience, and I know we all like know what the pelvic floor is, but at the same time, do we know what the pelvic floor is? So can you just explain like, a little bit of physiology, like what are we talking about specifically when we're talking about the pelvic floor and, you know, its kind of role in female physiology?
Sure. Oops. So male or female, whether you have male or female anatomy, you have a pelvis. We have the same bony scaffolding. So here's our hip bones. Here's our pubic joint at the front. We have our tailbone here, sacrum and tailbone at the back. So the pelvic floor is the group of muscles, and it's multiple layers of muscles, multiple muscles that form the pelvic floor. So the attachment points are the two sit bones, the pubic joint, and you can't see there, but the tailbone.
Yep.
Okay. So here we have in the female anatomy, urethra, vagina, anus, the layers of muscles. The first layer is primarily responsible for sexual response. The second layer is primarily responsible for the openings with the vagina, the urethra, the anus. The third layer primarily responsible for organ support, bladder, uterus, rectum. So here is how the organs are, you know, if you were looking at a textbook, here's our textbook anatomy. There's the three openings, and the pelvic floor is kind of slung underneath there. And the pelvic floor also, because of its attachment points on the spine and the pelvis, plays a role in our pelvic and spinal control stability. If everyone's heard of core exercise, it's the foundation of the core, but it's sort of left out of that conversation. And because of its relationship with our breathing diaphragm, when we take a breath in, ideally the pelvic floor is lengthening and expanding, as is the deep abdominals, the abdominal wall. When we exhale, the pelvic floor contracts and lifts. The belly naturally draws inwards towards the spine. And that creates a little bit of a sump pump action that's helping with circulation and moving lymph and what have you around the body as well. So these are all really important jobs that we've never been told. We've never been taught. Back, you know, when I was learning in that sexual health education, we learned about STDs. We learn about a little bit about male female anatomy, very high level. This is a penis, this is a vagina, and that's kind of it. And then this is a menstrual cycle, and really we deserve a whole heck of a lot more information than that. But that's essentially what the pelvic floor is. Those are the main roles of the pelvic floor. And when things are working optimally, don't even think about it. That everything's fine. And then as soon as something is not working, all of a sudden it becomes one of the only things we think about, because it influences so many things within our life. If we don't have continence, we are constantly distracted. Can people smell it? Can people see have I leaked? Is my partner going to see or smell anything? Is there a bathroom close by? Can they see my pad? Like, it's this constant worry. If we have pelvic organ prolapse, there's also the discomfort that you're constantly managing, the also fear of from a partner or intimate relationship, or even committing to things later in the day. That's usually when prolapse becomes more symptomatic. The pain side of things as well can influence intimacy, can influence social outings, can interfere with our ability to be present in whatever it is that we're doing. So really, like, I think it's the center of the universe. Of course, I'm biased, but it influences so many things in our life. And when it's working well, great. When it's not, then we have to address that so that all the other things in life are now sort of distraction free, and we have that freedom again.
100%. So you've talked about some of the indications for this, I think, that are the ones that we think to first, like incontinence being a major one, that organ prolapse being another major one. But this, as I understand it, can influence so much, right? It can influence recovery. It can influence athletic performance. It can influence, can you help us as clinicians think through, if someone comes in with incontinence or organ prolapse, we're automatically thinking about this, but what are some of the lesser known and the things that we might not be thinking of in terms of, symptom presentation that a client could be coming to us with, where we should be thinking about this?
Mm-hmm. I think honestly that pelvic health should be a vital sign, and it should be something that's included in all of regardless of what type of practitioner you are, it should be included in your health screening. Questions about constipation, questions about continence, questions about painful sex, questions about low back pain, frequency, so urinary frequency, urinary urgency, any burning, itching, any other sort of pelvic health symptoms. Those could all, and it's big, like that could become a lot of questions, but we are never asked ever. And if we see, right now I'm in Canada, and I know North America can be sort of similar, or United States can be similar, but we often have like 7 to 10 minute visits. And during that time, the clinician is really trying to rule out major life-threatening things. And we don't have time to go into all of those other questions. So for the practitioners that I believe are on this call, we have a little bit more time. And those questions can influence mental health. It can influence physical health, emotional health. So what that person is dealing with from a pelvic health perspective can influence all the other facets of their life. And a really big one that I've become incredibly passionate about, and I just completed a new certification for osteoporosis, is bone health. And when you think of, especially in the post-menopause phase, when somebody is losing a significant amount of bone within that, up to 10% within that first 5 years post-menopause, we know that 1 in 2, like 46, just over 46% of women stop exercising because of their pelvic floor symptoms. Oh. And so if our patients, if our clients are not exercising, those increased risks of heart disease, cancer, diabetes, osteoporosis are all going to be further increased because we are able, but we don't think we're able, or we're maybe told not to jump, run, twist, lift, like all the things that we should be doing. People are told not to do, or they self-remove themselves from those activities thinking it's going to make things worse.
Yeah, 100%. That's a really important point. You mentioned a couple here that I want to dig into and understand kind of the thought process. So something like constipation or low back pain, both of these can be due to so many different things, right? Yeah. How would somebody know if pelvic floor health is a piece of that puzzle? Is there a formal assessment for? I mean, I know a pelvic floor physical therapist, they do actual internal exams. In the absence of something like that, are there other clues that we can be looking for?
Mm-hmm. So low back pain, we have loads of research that shows the correlation. One in particular was done by a Canadian researcher that 95.3% of women presenting with low back pain have some form of pelvic floor dysfunction. So if this person has been dealing with this for a while, and if they have seen a chiropractor, massage therapist, acupuncture, regular physiotherapy, and they're still struggling, it could be that the pelvic floor is the missing link there. From a constipation perspective, if this person I'm drinking all the water, using all the fiber, I'm exercising, moving, abdominal massage, like doing all these things. I've seen a gastroenterologist.
Yes.
If they're still struggling, it could be tight pelvic floor muscles. So constipation is damaging to the pelvic floor, but sometimes part of the reason you're constipated is because of the pelvic floor. So if you have non-relaxing pelvic floor muscles, or if you have some pelvic organ prolapse, specifically called a rectocele, where the rectum bulges into the back wall of the vagina, poop and gas can get stuck in there, and it's very difficult to get out, which means you're going to need to strain often to get it out. So you would want to look, yes, I think honestly, every single woman should see a pelvic floor physical therapist once a year, just like you see a dentist for a checkup, even if you don't have any toothache or pain, you just go for your checkup. We've been conditioned to brush and floss and see our dentist once or twice a year. And I believe the brushing and flossing is the pelvic floor exercise, and seeing your dentist or your pelvic floor physical therapist would be beneficial to help identify when you've covered all of the other things that, are typically associated with constipation or typically associated with back pain. Things like posture. Posture is another well-known established contributor to pelvic floor dysfunction, particularly people who've lost their lumbar curve. So very flat low backs, very kind of flat glute, like lacking in booty, or even hyperkyphosis. So people who have a lot of rounding in their upper spine as well.
You mentioned something as well I want to dig into, because I think we think, and this kind of ties into the Kegels, like, is this that, it's all the do your Kegels. And I remember when I worked with a pelvic floor PT, it was a game changing. And I remember thinking, well, I'm just not strong enough. And she said, no, everything's so tight that they're not, it's actually the opposite. It was that I had to learn to relax those muscles before we could strengthen them. So could you speak a little bit to that? Because I think most of us just sort of default to thinking, oh, they're weak, right? Yes. We go straight into weakness.
Yes.
And they might be weak, but it might be, as I understand it, because of being overly engaged for so long. Is that?
Yes, exactly. Yeah. We think that a tight vagina, which is, we have this illusion that tight is strong, and that is going to increase my pleasure. It's going to increase the pleasure of my partner. That's what everybody wants and needs, is a tight vagina. And the opposite, I would argue, is true. We want adequate tone. We want good response time in those muscles so they can do their jobs. But just like any muscle in the body, if we have overactivity and non-relaxing behavior, that will impede blood flow and circulation. It will create fatigue. It can create discomfort and pain. It will interfere with the reaction time of the muscles. So from a pelvic floor perspective, if we think of that sling, that group of layers of muscles, when we have adequate resting length, the muscles can go through their range of motion as needed, depending on whatever task it is that we are faced with. Yeah. If we are, let's say, afraid of leaking, we're going to guard. If we are feeling like an organ's going to fall out, we're going to guard. If we have trauma or fear or anxiety, there's going to be a reciprocal kind of clenching. And I'm clenching kind of all over the place, like the shortening, tightening that happens in the muscles. If I sit with a tucked under pelvis all the time, if I stand with non-optimal posture, there will be an adaptation in the body where the muscles will adapt to a shorter, tighter state. Similar to women who may wear elevated heels, like high heel shoes. If they wore those every single day, their calf muscles adapt to a shorter, tighter position. So the same thing happens in the pelvic floor. And then when we have a short, tight muscle without the adequate blood flow circulation, it's now becoming fatigued. A laugh, a cough, a sneeze, a jump, something happens, and the muscles don't have as much range of motion to generate power. They are fatigued, so they're not going to react at the right time, and they can't generate the force needed for, again, whatever it is that it's happening. So that can be part of the reason why, again, somebody might be constipated. That's also a contributor to pelvic pain. It could be painful sex. It could be pubic joint pain, could be tailbone pain, could be hip pain, could be low back pain. Totally. And also if those muscles are not able to do their job from a support perspective, we can also get pelvic organ prolapse. And this is it's so opposite. People think, well, if I relax, everything's going to fall out. It's going to make things worse. And your PT exec told you the same thing. We have to relax first. We have to remind the pelvic floor of what it feels like to lengthen. And then from there, take it through its range of motion. Mm-hmm. And then start to layer that into whole body movement. But Kegels, most of us have heard the term Kegel, and I want to honor the fact that Dr. Kegel cared about his patients and he was using biofeedback to try to help them improve their pelvic floor. This is mainly in a postpartum population. Mm-hmm. But over the many years since he created or named that exercise, a Kegel is essentially a voluntary contract and lift and let go of the pelvic floor. The interpretation is squeeze harder, squeeze and hold forever and ever and ever. And we forget about the lift, and we definitely forget about the release.
What do you think of things like the jade egg and some of these tools that are designed or purported to act as, sort of weightlifting for the pelvic floor and for the vagina? What do you think that these can be helpful if used appropriately?
They can be, but it would never be where I would start. Mm-hmm. And the book and movie 50 Shades of Grey really made the balls, the Kegel balls, very popular. Everybody was running out and buying them thinking, my sex is going to be great. I'm never going to pee my pants again. And they absolutely can play a role, but similar to how we wouldn't go to the gym today if we've never worked out and pick up the heaviest weight and start exercising, we need to progress our weight there. So instead of investing your money into a device to start, invest in a pelvic floor physical therapist, even if it's one session.
Right.
So you get an understanding of what the status is of your pelvic floor. And from there, establishing, because there's so much more than just a Kegel exercise, or there's posture, there's hydration, avoiding constipation, the voluntary activation of your pelvic floor with whole body movement, your breath, your sleep, your rest, there's so many things that will influence your pelvic floor. We can't just say, go home and do 3 sets of 10 second total Kegels and you'll be fine. Right. That's not helpful and not accurate. So we want to make sure that we kind of cover all the bases and provide people the right direction, I guess, so that they are investing in the right thing first before we go and spend money, because sometimes that money is going to be wasted, because again, if that person does have tension and now they put in a jade egg or a Kegel ball and now they have to hold on even more, they can exacerbate the situation that they're experiencing already.
Yeah, that makes a lot of sense. Do you have any recommendations on how to find a really good PT therapist?
There's a few directories. So you can, in the United States, the American Physical Therapy Association, apta.org, they have a women's health directory. Canada, there's various physiotherapy associations. And I want to distinguish between nomenclature. In the United States, it's physical therapy. In Canada, in many parts of Europe, many parts of Australia, New Zealand, the term is physiotherapy. So it might be called pelvic health physiotherapy, women's health physiotherapy. In the States, it might be pelvic health physical therapy, women's health physical therapy. So they're the same, but just slightly different names. Cool. So you can look at the physical therapy or physiotherapy associations. There's also pelvicglobal.com. This is a directory started by a pelvic floor PT in Florida, Dr. Tracy Scher. And that directory is paid, so people do need to pay. And it is inclusive of many different pelvic health practitioners, not just physical therapists.
Right.
And so that's a place that people can start. But I also say go to Google and put in pelvic floor physical therapy or physiotherapy or women's health and the city or the closest city to where you live, and see there's still a shortage, but I say there will be some that show up. And from there, you can read the bios, you can look at the websites of people. It's a very intimate therapy. So you do need to, you need to feel comfortable with this person. That may not happen on the first session, but you'll have a pretty good idea on that first meeting if this is going to be the person for you or not. I like to, personally, I'm biased to people who have a movement background. Maybe they were in orthopedics before, maybe they have CrossFit certifications, maybe they've done some personal training as well. So people who have a movement mindset is something that I would look for in their background as well. And then really it's going to be dependent on the connection with that person. And if you don't feel like it's the right person, then you can absolutely go and find somebody else.
Right. Okay. This is great. I think also for practitioners listening to this call, having, especially if you have a practice where you see clients locally, definitely, if you are female, you should be doing this yourself too. But if you definitely want to have those referrals at the handy, build that referral team. Yeah. I want to talk about some of these age-related and stage of life-related changes. I think it's very intuitive how there can be damage and how things can impact us when we have childbirth. Can I actually go backwards before we go forwards in age? There are some people who definitely experience these issues earlier, even childbirth.
Even without childbirth.
Without childbirth. So can you, and even, I mean, we don't think of this as something that when they're young, that when we as women are young, it can be an issue, but it can absolutely be an issue. I'll just call myself out here. I was like the one who never wanted to jump on both feet at the concert in college because I would totally pee myself. So this has clearly always been an issue. So can you speak to some of the reasons that could be underlying that for somebody who's much younger? And then I want to talk about it as we are entering into the peri and postmenopause phase.
Yeah. Yeah. And this can, so thank you for highlighting, this can happen to anybody, and you don't have to have ever been pregnant. People think it only happens to people who've been pregnant. And if they've had a cesarean section, oh, they're fine as well. But this can happen to anybody, even teens, very fit people. So some of the other contributing factors to somebody who maybe hasn't had some of the other more common risk factors like pregnancy and childbirth, I mentioned posture. So especially with the world we live in, with the looking at our phones all day, every day, very hunched over postures, forward head, oftentimes with the amount of sitting that we do and sitting, looking at our phones and scrolling, we have that sort of C-shape spine, tucked under pelvis, rounding upper back. We know from research, both of those can be contributors to pelvic floor dysfunction already and shortening of those muscles. So posture will be a big one. Constipation will be a big one. Dehydration will be a big one. And especially if you're, regardless of the age you are, if you are already struggling with urinary urgency, urinary frequency, or leaking, your mind will think, my compensation will be just don't drink anything.
Right.
Because if I don't drink, then I won't leak. And if I don't drink, I won't have the urge, which sounds logical, but it does concentrate the urine. That irritates the bladder. The bladder will signal you more strongly and more frequently to get that concentrated urine out. So drinking more water is what we should be recommending to people for many different reasons, but especially from a pelvic health and bladder health perspective. So dehydration, poor diet. So the inflammatory foods, inflammation, we know what that does all over the body. The pelvic floor is not immune to that. So any sort of inflammatory foods, reactions to certain foods, vitamins, minerals, like common bladder irritants. So coffee, caffeine, alcohol, artificial sweeteners, gluten for many, dairy for many, acidic foods, carbonated beverages, spicy foods. I don't know if I said that one already. So those are all well-established bladder irritants. Doesn't mean that everybody's bladder will be irritated by all of them, but those are things that we want to look at if they are potentially consuming in their diet. Stress and anxiety and poor sleep. Yeah. So, and I feel like that's the worldwide pandemic now, stress and anxiety and poor sleep, right? So and we have literature to support this as well. And the reaction of the pelvic floor muscles when looking at stimuli that is upsetting. This was in a published. So there is and this was looking at specifically in a pelvic pain population. So muscles, the pelvic floor muscles will react to fearful, stressful, either immediately happening or perceived in the future or reflecting in the past. And people will say, I have a nervous bladder or I have an anxious bladder. And that's that heightened sympathetic state will then also aggravate the muscles. And if you look at, so this is the inside, you can see again some of the layers, and I'm just going to add in the bladder here. So this is where the bladder nestles. So ideally, when we are in optimal posture, we have the gentle curve in our low back, we have our hip bones in the same plane as our pubic joint, and we have a little bit of a shelf supporting the bladder. Mm-hmm. Okay, but right underneath that bladder, we also have those muscles right there. And so if we have tension in them, they will irritate the bladder. And if we couple that with sitting or standing in a tucked position, mm-hmm. where the muscles are also adapting to a shorter, tighter state, we will be dealing with constant tension that will give us more symptoms. And then we start to eliminate, if somebody has the sensation of needing to void and they're constantly responding to that, even though it may be inappropriate, that is then training the bladder to signal more frequently. And so there's this training piece that comes. People who have endometriosis or adenomyosis or PCOS, those are also contributing factors to inflammation, to pain. And then somebody who's already in pain, there's then going to be a heightened response in the muscles, and you get into kind of this vicious feedback loop.
It's amazing how much it really, I can understand more and more the deeper we get into this conversation, why you're saying everybody should have this. Just like you get your teeth cleaned, we need to be going to because I can't think of a thing on this list that I can't think that somebody could be. I mean, I guess it's feasible that you could actually stay away from all of these things. I think about myself back in college, and I'm like, yep.
Yeah. And the other thing that I didn't mention, which I think we need to address as well, is we talked earlier from a bone health perspective that we need impact, we need heavy resistance training. And what I have seen, so I've been in the fitness industry for like close to 30 years, and it seemed for a while there, it's starting to change now, but for a while, every single year was something harder, something more intense, something that was, that was happening because we, as a population, were becoming more sedentary. We felt like we needed something harder. So high impact, heavy loading is something that we need, but there's also going to be kind of like a tipping point. We have to have this balance, because too much of it can also be detrimental to the pelvic floor. So we have research that looks at chronic heavy loading, and that is more like occupational. So somebody who might be carrying, so a mail carrier, or people who work in hospitals who do transfers. That's heavy load consistently. We also have some evidence that looks at Olympic lifting. Power lifters, CrossFit athletes are usually struggling with more pelvic floor symptoms. However, none of these people have been given any sort of pelvic health advice to start out with. So I feel like if we, again, shifted this earlier in life and gave people the tools and had people seeing pelvic floor PT, doing pelvic floor exercise, and incorporating it into their workouts, I think those numbers would change. So I want to highlight that, yes, we have some evidence to show that heavy lifting, running, especially running, can influence fecal incontinence more so. They can be absolutely contributing factors. That doesn't mean running is bad. It doesn't mean that resistance training is bad. We need the pelvic floor to be able to, and we need to establish good connection with the pelvic floor first, address all of the other things that could be influencing, and then progressively load it so that we can tolerate those activities.
Yeah. The time that I worked with that pelvic floor therapist was a time when I was training very actively. I'm a distance runner, and was doing a lot of really intense track workouts. And I would have this experience where I would see when I was at a specific threshold in my running, because I would immediately start to wet myself, to the point where like I was buying special underwear to train in, and I would never train in anything other than black. And to this day, I will not wear anything other than black in a race, because I know there's just a point at which I push myself and it's like, oh, just went past that little threshold. So I think this is, and it is a missing piece. It is such an important missing piece. I want to come to the perimenopause in a second, but is there, like, what age would you suggest people start making these annual appointments? Is this something that as early as puberty, after puberty, before puberty? Like, when do we start thinking about this?
I generally say around the time you become sexually active. And that is, that could be different for lots of people. And it's also going to be dependent on the conversations that are happening within that household. There are some people where that is a very hard to talk about, taboo subject, not talked about at all. And there are other people who are very open and talk about absolutely everything. And then there's the in-between there. But I think if we are kind of planting the seeds and not afraid to name proper anatomy, and the way that, like, the different kind of, I always say building a healthcare team. I think if we can talk to our kids about building a healthcare team and not just relying on my doctor, then I think that helps open up. And this is what my healthcare team looks like. And these are all the people who I see to help manage this vessel that we have here, because it's a lot, and we can't just rely on one person's opinion in training and education. We need a lot.
Yeah. I am going to get to the perimenopausal, but now you opened up another question for me. I could talk to you for days. I love this. So with, with that, when somebody becomes sexually active, I'm going to imagine as well, if there's any kind of trauma, any kind of sexual trauma, that could have pretty major implications in this area as well.
Yes. And there are more and more pelvic health PTs who are also taking additional training to become trauma informed. So I would say not every single PT will have that background and training, right. And they will often, and they know their limitations. So they will also collaborate with mental health practitioners as well. And even if they are trauma informed, I still feel like that's another person that would be helpful. But we want to make sure that young people, especially as they're starting out in their sexual health journey, that they, especially women, that they know and appreciate and understand that they are deserving of pleasure, and that it should not be painful. And aside from that very first time, if their hymen has not been broken, there might be a little bit of discomfort there. But after that, really, it should not be something that is painful. And I think a lot of people interpret that, well, I guess that's just the way that it is for me. And there's many different pain categories as it pertains to pelvic health, and working with a skilled PT to help you unravel all of those and understand what it is that you are dealing with is a really important piece, so that, again, we're setting people up for a healthy life of intimacy going forward.
Okay. Perimenopause and menopause. So let's talk about what are some of the things that are happening that are exacerbating these issues. I'm sure everything that we've talked about still comes into play. And more. And more. And that there's more.
So the two big ones for me in the perimenopause phase is thyroid function and, of course, hormones. There's a lot of tumultuousness happening. Yeah. But thyroid is a very commonly overlooked piece. Yeah. And we know how many people, I'm assuming your population will be well aware of how many women struggle with autoimmunity who are never screened properly from a thyroid function, and low thyroid is a contributor to constipation. It's also going to be disruptive to their hormones. And so then if we are in that loop of we're not sleeping well, maybe we're using coffee in the morning, which is a bladder irritant, and then we're finishing the day with wine, then I'm not sleeping well. So we have inflammation, we have poor sleep, which also we know from literature will exacerbate symptoms. We are consuming bladder irritants. We are probably not eating well through the day, so we're going to become constipated. And we just get into this SHIT storm. I was for me, where you're not sure I remember going through it, not knowing I'd never heard of the term perimenopause. I didn't know all of these weird symptoms that were happening and why. So the hormone piece and the thyroid piece are two fundamentals that I think if you don't do that type of screening in your practice, working with somebody who you can refer your patient onto to get those screens, so you have that piece of information. Again, there's also then the dehydration component. People are, resorting to their caffeine. They're busy. They often are working full time. They may still have kids at home. Maybe they're now in the sandwich generation and they have aging parents. And so everyone else's care is taking priority over themselves. And at the end of the day, they are like I have people do what's called a bladder diary. And this is something that can be a helpful tool for practitioners to use as well. I have one on my website for free. You can Google them. You'll find them. It's essentially a way for patients to track what they're eating, what they're drinking, how often they go to the bathroom, what symptoms they have either leading up to or afterwards. And it can help them start to identify foods like the bladder irritants, the behaviors, the peeing just in case. I'm going to leave the house. I'm going to go pee. I'm going to pee just before my exercise class. A lot of people leave halfway through their exercise class to pee. They're thinking, if I just continue to empty my bladder, I won't have leaks and I won't have urges. And as we were talking about earlier, that can create the opposite problem. So having somebody fill out that information, also then they highlight, oh my gosh, I think I drink a lot of water and I really have 2 cups in a day. And I drink a lot more coffee than I should, or I drink whatever it is, carbonated beverages. So having them aware of how much water they are or not drinking what bladder irritants they might be consuming, how much fiber they may or may not be eating, is an important piece as well. And then the other big piece on that is waking at night to pee. And during the perimenopause phase, a lot of people start to experience sleep disruption, and it's very rarely the bladder that's waking you up. Yeah. Unless you have maybe sleep apnea or blood sugar issues. You're waking up for a hot flash, you're waking up because of blood sugar, you're waking up because of a noise, snoring partner, many other reasons. And then you have trouble falling back asleep. And then because you're getting anxious and you're frustrated, your sympathetic nervous system, and then you're going to have to get the feeling to go to the bathroom, and then you're going to go. And that happens multiple times in a night. And now all of a sudden you're waking 3 or 4 times a night, thinking it's your bladder waking you up. And it's very rarely not. So that nighttime waking is also going to exacerbate all of the other challenges that we're experiencing in life. But that's a really, really big one. And one of the quickest wins that people have when they start addressing their pelvic floor and their lifestyle is that they can sleep through the night again. And sometimes there's some thyroid and hormone stuff in there as well. But
yeah. Are there some things that we can advise both the audience here as well as them for their clients, even before actually going and getting formally assessed by a PT therapist? Is there stuff that people can be doing anyways, some of the basic things, or is it really hyper bio individual based on what's going on for that individual?
There's a lot that people can do on their own, and yes, there's going to be nuance in there for a lot of people. We're all going to have our own health histories and current life experiences for sure. But something like footwear, this is something that not a lot of people think about. If we can help sort of guide people towards healthy feet and healthy footwear, a lot of people call it barefoot shoes or minimal footwear. There are oodles and oodles and oodles of companies out there now making shoes that are healthier for our feet. The postural adaptations that happen, many of them start with our feet. And if we are wearing footwear that is constantly elevating our heel, and even the standard footwear that we think of as running shoes, pretty much all of them have a positive heel, meaning the heel is higher than the forefoot. And that small, it can be like barely an inch. It can be very, very tiny, but those micro adaptations will translate up the chain. We develop shorter, tighter calves, shorter, tighter hamstrings. The hamstrings attach up into our pelvis. It brings our pelvis into a posterior tilt. And the toe box at the front narrowing, like our socks and our shoes will cause it makes us conform to the shoe rather than our toes being able to spread. And so that's also narrowing our base of support. And if we think of from an aging perspective, I see so many, the term geriatric shoes, a lot of older people wearing very narrow based shoes with very narrow positive heeled shoes. And I think that's increasing their fall risk. We need to get them closer to the ground, and we need to allow the feet to move and feel the ground so they can strengthen. That's how we work the foot muscles. If we're constantly cast into narrow toe box, positive heeled shoes, we are weakening our feet and we are tightening the muscles up the chain, which can contribute to poor pelvic floor response. So transitioning, and I emphasize the word transition, we don't just go and buy a pair of minimal shoes and just start wearing them. We need to transition out of what we're currently doing and into more minimal footwear. There's a really great website I have no affiliation with called Anya's Review. So Anya is a woman who went through her own foot health journey and now posts a lot of education, and also she shares all of the different brands and she shows how to make them stylish, and it's a really good resource. So that's something that not a lot of people think about, just what we put on our feet, how that can influence a whole bunch of other things in our life.
I would never have thought you were going to talk about footwear, ever. But it makes everything that you said, it makes perfect sense. It makes really, really good sense. I know myself moving, I had an injury in the fall. So I have not been running, and I've been spending a heck of a lot more time in the gym. And I have noticed, at the beginning, I was just training in the gym in my running shoes, which all have that, that heeled raised heel, as you mentioned. And I have recently transitioned into just flat shoes, even just like a pair of Converse, like nothing fancy, like just something basic. And it's been kind of amazing how much better it feels. And I think you're explaining to me why.
Yeah. Yeah. Even barefoot, like people, the rules of the gyms are okay. We're not going to have multiple people in the gym being barefoot, but if you're in your own home gym, take your shoes off. If you drop a weight, your shoe's going to do nothing to protect your foot. So just, just be barefoot. Yeah. Something else that I would say that, again, from a practitioner perspective, that we could be recommending to our clients from a vulvovaginal health would be vaginal moisturizer. And we think of, like many people will spend thousands of dollars on creams and serums and treatments for the skin on their face. And we have very similar tissue in our vulvas and vaginas, and we benefit from care and products that can help us retain moisture. So hyaluronic acid is a very common ingredient in vaginal moisturizers, and there's many different brands. Some of them are gels, some of them are little ovules, some of them are more sort of serum based, and it's really going to be personal preference as to which ones you prefer. But moisturizing your vagina daily, vulva vagina, is really, really important. Estrogen, vaginal estrogen. So if you're dealing with people who have reached or are approaching their menopause, starting the conversation of vaginal estrogen. And of course, there's lots of fear around estrogen, but some great resources for people to look at would be the Unboxing Menopause campaign. This is it's petitioning the FDA to change the labeling on vaginal estrogen because it is currently not medically accurate. People read the label and think they're going to have a heart attack and a stroke and get cancer and they're going to die. So many people are prescribed vaginal estrogen, which is great. They should be, but the majority of huge majority of people don't take it because they're afraid of the label and it's not medically accurate. So go look there. Dr. Kelly Casperson, Dr. Rachel Rubin, Dr. Corrine Menn, very prominent medical doctors who are sharing a lot of information for people. But that, to me, I consider almost like an essential nutrient from the time of your menopause for the rest of your life is vaginal estrogen.
I see there's lots of questions here in the chat. So I'm going to skip over to the chat and then I'm going to come back to a couple of things that I want to make sure we do. Oh, we have a testimonial from Anne. She says, I'm grateful to Kim's Buff Muff program for helping me heal after a fibroidectomy and DNC last year.
Cool.
There's a couple of questions. The Buff Muff app includes, so this would actually be, I will ask her question, and as part of it, if you can explain, because that was going to be my next question, is asking you to kind of give us some highlights of what the Buff Muff method is specifically. She's asking, the Buff Muff app includes meal plans aimed at digestive support through fiber, probiotics, and antioxidant foods. From a functional nutrition standpoint, how do you integrate these gut supportive nutrients to optimize estrogen metabolism and thereby support tissue health and recovery in the pelvic floor muscles?
So in terms of my scope of practice, I am referring out for people from a hormone support perspective. Right. So as a menopause support practitioner, I can provide advice and guidance and direct people on to who. So in terms of an estrogen metabolism, I wouldn't say it's necessarily within my scope to comment specifically on that. However, knowing that digestion and pooping well every single day is incredibly important to support our estrogen metabolism. The very first, if somebody was to just buy the initial Buff Muff method, it's inclusive of a section on constipation and a meal plan specific to increasing fiber. I want people not to be afraid of, people think of fiber as it's going to taste like crap and it's not going to, it's yucky. And so many things are delicious that have lots and lots of fiber. And so it's a 5-day meal plan to give people a bunch of different varieties. So increasing diversity for their gut. I also have a probiotic called Footwear that's supportive of gut health as well, but really talking about the importance of pooping. So many people don't appreciate, nobody likes to be cranky pated, but they don't really appreciate why it's so important from a detoxification perspective. So it's hydration and constipation are the two. We have to start there before we start even going through exercise, because if you are not pooping well and you are constantly dehydrated, you're not getting the SHAIT out, and you're not going to feel like moving. You're not going to feel like doing all the other things that are going to be beneficial for the pelvic floor.
Well, and that's really helpful for these practitioners to hear too. We always start with gut healing. So, and getting clients hydrated and helping them, to get those bowels moving, that is a top priority. So that aligns really beautifully with how, they're working already. So that's fantastic. She asks a follow-up question here. Could you walk us through how specific polyphenol containing foods like berries, cruciferous vegetables, green tea can help modulate pelvic floor inflammation and collagen remodeling for women at different stages of perimenopause?
So again, not being a nutritionist, it's, I would say, out of my scope there. I will share, though, from a collagen perspective, I do have an article on my site. If you go to vaginacoach.com/blog and you put in collagen, you'll find the article. And what I did was I wanted to look at, if collagen is so beneficial for all the other tissues, and we have those similar tissues within the pelvis and the pelvic floor, could it be beneficial? We don't have evidence directly to say if you supplement with collagen, it will improve your prolapse or it will improve your incontinence. We do have research that looks at deficiencies of specific types of collagen, and that population being more prone to pelvic organ prolapse and pelvic floor dysfunction. So we can infer from the lack of certain types of collagen that if we were to supplement or be eating foods that would be help us augment that we could potentially help. So I would direct people there from a collagen perspective. It's a very kind of researchy article. I would say it's beyond my scope, really, from a polyphenol perspective. I don't know of any direct, I know of research from a vitamin D perspective. I don't know from a polyphenol perspective as it pertains to the pelvic floor.
Beyond women's health, could this be a factor in young children struggling with urine incontinence? And is there a particular way to address pelvic floor health in males, or the same would the same PT work with either gender?
Yeah, so children, absolutely. It can be poor toileting habits. So if the mom is always telling, or a parent, doesn't have to be the mom, but if the parent is always saying, okay, we're leaving the house, go pee, that in and of itself can be setting that child up for not trusting their own signals and going pee just in case. So that's one. Constipation, of course, other anxiety behavior. So all the things we've talked about can absolutely be present in children. And there are pelvic floor physical therapists who work specifically with the pediatric population. So it's already, I wouldn't say it's really difficult to find a pelvic floor PT, but there's not millions of them ever. They're not super abundant, but it's definitely harder to find a pediatric pelvic floor physical therapist, but that's the person I would recommend seeing. In terms of the male population, again, they have the same anatomy from a bony scaffolding. They have a pelvic floor musculature. They don't have a vagina. They don't have the uterus. They don't have the same hormonal fluctuations. They don't go through it. Like all of those are established differences. But in terms of the principles to overcoming pelvic floor challenges, many of the same principles apply: posture, hydration, constipation, retraining the reaction time of the pelvic floor, learning to relax the pelvic floor. The differences would be in cueing. So visualization and cueing is really important, because this is a group of muscles that we can't see. We can't go to the mirror and flex our pubococcygeus muscle, right? And see it. So we need feedback, visualization, biofeedback, cueing, imagery to help us identify and connect with this group of muscles and coordinate it with the breath. Men are the same. They just would use different cueing. So from a female perspective, very common ones that are helpful. From a lengthening perspective, you might think of blossoming the vulva. You might think of spreading the sit bones, or the pubic joint tailbone to sit bones, kind of like the diamond,
right,
opening and recoiling. For men, the sits bones can be helpful, but blossoming their vulva, they don't necessarily have one. So it might be blossoming the anus. It might be blossom your butt cheeks. From an activation perspective in women, it might be sipping a smoothie through a straw with your vagina, or picking up a blueberry with your vagina and your anus. For men, it may be pull the turtle into the shell, or imagine walking into a cold lake, or lift your scrotum away from a pin or a flame. And none of those, I mean, from a research perspective, what was established for women was an anal cue, so squeezing the anus. What was established for men was shorten the penis. And that has been changed slightly to pull the turtle into the shell, because not many men want to think of shortening the penis. So, but those are, like, if you look at research, that's what it says, but that doesn't mean that that's always going to be the best cue for everybody. You have to find your best cue. And you can do that with your own biofeedback. So that could be a finger, it could be a toy, it could be a partner, but gold standard would be to see a pelvic floor PT in person.
Could you use that in terms of, the kind of circling back to what we started with the relaxation? Is there a way to kind of self-assess and know whether you are, in the absence of working with a formal therapist, is there a way to get a sense of whether you are relaxing, or sort of just to assess that side of the equation?
Mm-hmm. So if you have, fingers are, if you have your own finger, the challenge with that is in terms of us inserting a finger into vagina, we're usually in an awkward position and we may not be able to fully relax. So if you have access to a partner or a biofeedback device, there are some biofeedback Kegel exercise devices like the PeriFit or the LV. They could potentially help you see the difference between a contraction and a relaxation. But generally, it's going to be a symptom change if you do it over a period of time. But I also want to highlight that it's not just about, it's not as easy as, okay, just relax the pelvic floor, just relax. And it's surrounding muscles. It's the glutes, it's the hips, it's the belly, it's the hamstrings, it's the calves, it's the feet. So by working on all of the parts, and kind of, we talk about gut health diversity, we want movement diversity as well. All of that in turn helps us improve our posture, which in and of itself can help the muscles find their kind of optimal resting length as well. So practices like, if you're sitting, make sure you're sitting on your sit bones and your vulva or your perineum, as opposed to with your tailbone tucked underneath you. So that's something that somebody can do. But from an evaluation perspective, it's going to be if they have leaking, urgency, frequency, painful sex, burning, sensation of something being in the vagina, that can all be a sign of tightness. But urgency, frequency, prolapse can also be laxity. But I would say, when I talk to my pelvic PT friends, most of the population they have are dealing with tightness. So we can just kind of default. I always start all of my workouts with release, and we always end with release, because it's so important.
I have a quick follow-up question to something you mentioned earlier, which was the parents asking their kids to go to the bathroom before leaving, which 100% do. I mean, we have a policy. It's like, before we go on a long car ride, everybody has to sit in the toilet and count to 10. Pee happens, great. If it doesn't, no problems, but you tried. So is that a bad thing to do? Am I in? So yeah. Oh, wow. Okay. So I stop.
Yeah. Because it's, we should, like, what should happen is the bladder is constantly filling.
Yeah.
And it will get to certain levels where it'll be sort of like a gentle, we're getting kind of full, like, it's not urgent. You don't need to find a bathroom right now, but just, we're getting there. And then the next signal will be sort of like, okay, you might want to start looking for a bathroom. And then we can also get to the point where we're like, I need it right now. Where is it? And it's urgent, and I might lose complete control of my bladder. So that messaging is a brain bladder connection. If we come in and we pee before those messages happen, before we're getting those signals, then we are training the bladder to signal more frequently at inappropriate times, and messing up that signaling. So once in a blue moon, like, if we know there's going to be heavy traffic and we're not going to be able to stop, of course, a pee just in case, but you're going to tell your bladder, this is a just in case pee. You don't have to say it out loud, but say it in your mind. But just don't make that a daily or a routine behavior, because your bladder will be like Pavlov's dog. It'll become conditioned. Every time you leave the house, you're now going to have to go. Every time you hear running water, you're going to have to go. Every time you go to your exercise class, and you really shouldn't be emptying when you don't have to.
That's okay. Well, you just changed things for us at our household immediately. So many gems in here. So tell us a little bit about your Buff Muff method. And I know you certify health professionals in this. So can you tell us a little bit about the method and then the practitioner training program? What kind of health professional would qualify to take that?
Mm-hmm. When I was first learning about the pelvic floor and understanding that it's a group of muscles, being a personal trainer, I said, well, why aren't we using the same principles we do for the rest of the body for the pelvic floor? We have type 1 and type 2 muscle fibers. We have endurance. We have sprinters. We can train for power. All these things we can do the same. And this Kegel exercise, again, I don't want to take away from the work that Dr. Kegel did, but we need to expand on that. And a lot of the symptoms that people struggle with are not when they are lying in bed or sitting in a chair doing their 3 sets of 10-second hold Kegels every day. I also don't know how many people are going to dedicate 3 separate times in a day to train their pelvic floor. So we need to take that as our foundation. We need to establish this connection, or reestablish the connection between the diaphragm and the pelvic floor, our breath and our pelvic floor. Then we need to layer it into movement. We need to train the pelvic floor dynamically. So once we have understood and we appreciate what, when we inhale, the pelvic floor lengthens, when we exhale, the pelvic floor contracts and lifts, that can sometimes resolve people's symptoms, but that doesn't mean we stop. Let's now then go, okay, bring it into squats, bring it into lunges, bring it into push-ups. So the method really comes down to working on our alignment, coordinating the breath. I call it the core breath, and then coordinate it. So A for alignment, B for breath, C for coordination. We coordinate that breath into whole body movement. So we are also going to be helping our heart health, helping our bone health, helping offset age-related muscle loss that also happens in the pelvic floor, but in the rest of our body as well. And then our workouts become really literally whole body. We can bring the pelvic floor into a bicep curl. We could bring it into an overhead press. And the pelvic floor is, I said earlier, the center of the universe, but it's where we develop or kind of get our power from. And when the pelvic floor is working optimally, it reacts at the right time with the right amount of force, we then can manage those loads and progress past them and bring power into those movements. So a lot of people say they can lift heavier and last longer in their workouts when their pelvic floor is working optimally. So the method is really looking at the lifestyle pieces, going through the ABCs, and then progressively loading. We get into jumps, we do power training, we do endurance, we do all the things so that we can age powerfully. If we are sitting and stopping exercise because of our pelvic floor symptoms, there's a lot of suffering ahead of us. And incontinence is one of the leading reasons why the aged population is admitted into nursing homes.
Yeah.
Proven fact in research.
Hey practitioners, can we have an honest chat about fertility cases for a minute? When a client walks in and says they're trying to conceive, do you feel confident or a little unsure about what to do next? Let's be real. Even with advanced training and clinical tools, fertility cases can be some of the toughest ones that you'll face. There is so much going on beneath the surface, and when your clients aren't getting the results they want, it's hard not to wonder if you're missing something. Here at Restorative Wellness Solutions, we want to make sure you feel 100% confident and well-equipped to help every single fertility case that walks through your door. That's why we're inviting you to join us for a free 3-part live fertility masterclass series where we'll walk you through how to tackle even the most complex cases step by step. We're covering everything from laying solid nutritional foundations to figuring out which tests to run to using simple sex-specific tools that help your clients get better results. Whether you're brand new to fertility or you're looking to go deeper, this series will give you a practical clinical framework that you can start putting into practice right away. So don't wait. Head to the show notes, click the link for Precision Nutrition for Fertility, and grab your free spot now. You and your clients will be so grateful that you did. Interesting. And sobering.
Yeah.
Is there a too late?
Never.
Is there a point at which, I love that. Okay, good.
Never too late. I will say that there are people who will overcome, in my program, I've seen overcome urgency, overcome frequency. They don't wake up at night to pee. They don't have stress urinary incontinence. Some people improve or even reverse their pelvic organ prolapse. They don't have painful sex anymore. That is all possible. That doesn't mean that every single person will experience those same things. Right. There are certain times where you can do all the exercise in the world and we can't improve a stage 4 or stage 3 prolapse to the point where you have no symptoms. What I want to say there, though, is we have other options. So surgery is here as an option, and it can absolutely be a fantastic option. It should never be where we go first. Pelvic PT, hypopressives, pessaries. Pessaries are like orthotics for the pelvic floor. Changing posture, all the things that we've talked about are all what we should be doing to try to alleviate these symptoms. And if they help, great, then you're going to carry on doing them. It doesn't mean that you stop. Like, we don't stop brushing and flossing when the dentist says we don't have cavities. We keep going. Yeah. You're going to carry on. And if you don't get to the point where you've improved the quality of your life enough, then maybe surgery is now an option. And everything you've done is your prehab. It will be your rehab. And it will also be even more important after your surgery, because you've now had a change to the landscape. You have scar tissue. You've had a trauma, even though controlled, it is a trauma to the body. We need to support the muscles through that as well. So I would say, yeah, there will be times where somebody may benefit from a surgery, but that doesn't mean that they shouldn't do the exercise, because they're going to have to do it after. So you might as well do it first and see where you end up.
I love that. I love that. For practitioners who are wanting to dig into this themselves, is it only people who are already trainers and movement therapists in some way, shape, or form or is it open to other types of practitioner as well?
Yeah, we've opened up to pretty much everybody. It was initially designed for movement fitness professionals, but we've had naturopathic doctors, we've had midwives, we've had lots of people take it, and even if you're not a movement professional, understanding the basic, there's some basic movement we can teach. You don't have to be a personal trainer to show somebody a bridge exercise or to get them to connect with the core breath. And I will say right now, if you were to go to my website, it would show 2 certifications that are currently being updated. And in about a month, it'll be the full relaunched Buff Muff Method practitioner. So it'll be an updated kind of full life cycle of women's health. There's movement in there, but you'll learn a whole heck of a lot of other stuff in there as well.
Okay, awesome. How do people stay in touch with you, stay connected?
vaginacoach.com is my website, and social medias, all of my handles are at Vagina Coach. I hang out mostly on Instagram. I do have a YouTube channel where people can get an idea of kind of what the method looks like when you incorporate it into a workout. There's some release things on there, so people can get a taste of what I do there. And I have a podcast as well called Between Two Lips.
Love it. And I think you shared your pelvic floor book with us.
The one I shared with you is called The Inside Story. So this is one that it sort of covers the 3 main phases that women go through. Not everybody, again, will become pregnant, but it's pregnancy, motherhood, menopause. And I would like to rewrite it and add a teen section in there. But it covers the main, what is the pelvic floor? How do these main phases of our life influence the pelvic floor? And then also I've invited pelvic health practitioners from around the world to contribute their tips. And this could be mind body, it could be diet, it could be sleep, it could be exercise. And I wanted it to, first of all, introduce other pelvic health practitioners around the world, but also help people understand that we can have an overriding healthcare team. We can also have a pelvic healthcare team where it doesn't just have to be that pelvic PT. It could be other fitness professionals or nutritionists, functional diagnostic nutrition people who can offer tips that could potentially be helpful from a pelvic health perspective.
Wonderful. Well, we'll make sure to share all of those links in show notes and beyond.
Thank you.
Kim, thank you so much. I have learned so much. This has been fantastic. Thank you for the work that you're doing. It's so important and so needed. And for those of you who are intrigued, I hope you book your annual appointment with a pelvic floor therapist, and check out more of Kim's work.
Yeah, thanks for having me. This is what helps move the conversation and gets it into the ears of other people. And that's what will change the world. So I appreciate you sharing on your platform. Thank you.
Yeah, thank you.